We're very happy to meet again. We've been having this weekly briefing since this virus was detected in Rwanda. And we're going also to be updating you again where we are. But we have some latest updates on some of the questions we've been asking ourselves, tracing back this virus, but also sequencing this virus, which is important for our response, but also important for the science and preparedness and response in general. So I'll be using a few slides so that we can have better visualization of some of this data before we get your questions, comments, and answers. So this is a simple way to put everything on one slide. This is a dashboard that we got from our command post. The teams have been working around bringing these statistics together, guiding everything we've been doing since day one. So as you've seen every evening, we are reporting new cases detected, recoveries, death, case fatality rate, and also how we track every contact. And we're very happy to say that in the last 5, probably 6 consecutive days until we confirm the test of today, with 0 new infections and 0 deaths consecutively. We wish this continues, but even if we had 1 case, for us is an opportunity to continue to trace every single contact and case before we put final end to this outbreak. So as you can see, we've done a lot of testing, more than 4,700. This using PCR is not an easy procedure, but we've always upgrading our lab capacity in every province. We have a lab doing these tests. We've seen a trend of recoveries that was actually better than what was predicted, which is something also to highlight with the healthcare workers doing a great job to make sure every single life can be saved. I'll be showing some of the latest news about case management. So this slide has a lot of information. It's probably just to put everything together, but I'll be speaking about some of these highlights. But the most important information is 62 cases. We still have 3 patients that are not yet out of this treatment center. Hopefully some already having some good sign that we may get out of this treatment center soon, testing twice within 72 hours period. And unfortunately, we've lost 15 people, mostly healthcare workers, since the beginning of this outbreak. And we had also recoveries, 44 already back home. They are still being followed, but the good news is that they don't have the virus, and their general status is also improving. I mentioned the case fatality rate, 24%, which was really a result of a joint effort that all of you have contributed to. We've also seen that most of the patients we had were young, around the age of 30, 35, which is the workforce among these health workers. Maybe that was a factor that to think about in terms of case fatality and recovery rate, but also early detection and treatment. So in terms of gender, we've seen really no difference. Depends on the service they're working in. But also we've seen that the early days were most complicated. That's where we recorded more death than the days we started to have now. You know, you detect, you treat, and you follow, including up to the ICU. We have also recoveries from intubation that we'll be talking about. So in terms of epidemiological observation, those who are in this field for some time, these are the best way to visualize the trend. The very first 2 weeks were a bit not different. That's the time we were still getting to the core of the virus. So many people that had been exposed were being tested. So there's no difference between week 1 and week 2 in terms of new infections. But we start to see a significant trend towards the week 3, where a 50% reduction was observed, which is the best indicator. You can see that an outbreak is dying when you start to see that 50% decline between week 1 and week 2. So we saw that at week 3, which brought a lot of hope that this is going to be contained quickly. And now this week, we are seeing even better results than 50%. We're observing 92% decrease in new infections comparing these 2 weeks, which is really a good trend that most of you have been observing online and our daily data published. But this is probably the best way to observe this trend and how we can get to an end very soon. So again, I mentioned before in a previous briefing that healthcare workers were the most hit. And the first on this left slide shows how healthcare workers were the most recorded infections. These are the cases by occupational profession. So the first one, you see the long green bar are healthcare providers, and the following box are actually students who are actually in the medical field. They are at the hospital in those specific department, ICU. By the time this virus was being detected. So it explains the core of the virus and who was most affected. And their contacts are generally mostly the staff working in those hospitals, the 2 hospitals. The case fatality rate, 24%, I mentioned about, and also the age distribution, which is also showing here that majority were aged 30 to 39. So in terms of contact tracing, I see a number of epidemiologists in the room. This is probably one of the most interesting slides for you and for us as well. We can say that this outbreak was into one cluster that had 3 major branches: the King Faisal, Seashika, and also the index case where our index case we'll be talking about, which also had family friends who were in the hospital by the time this virus was affecting the hospital. So this is what you've seen on our daily update, that there is a hospital cluster. This is how you can see that. The red dots are cases, and the blue are the contacts. We've been exhausting contacts and contact of contacts so that we don't miss any case. So this picture shows all those connections. And you can imagine how many contacts. Sometimes we're receiving feedbacks from people saying, I'm listed as a contact, but I never been in contact. But it's always better to know than to miss that. If you've been in this room, you may be considered as a contact. But that's how the number keeps growing. But it's also to show how the level of exhaustion and search of cases that has been happening with most of your support. So there's a question that kept coming on where this infection came from and who is the index case, also the index case. So in the early days, the first 2 weeks, we had a case that we've been following from our initial testing. But I can say that after a deep search combining sequencing research, combining epidemiological search, combining diagnostic search, combining clinical information, and also One Health information, we came up to our index case, which is now known, at least a very high probability and high precision that this is our index case, which is very closely linked to a zoonotic origin. So this is something we confirmed recently after all this testing combined, and that is going also to help how we adjust and increase our surveillance capabilities moving forward for this outbreak, but also for preventing potential future outbreaks It's a very important information for us and for our partners who have been working and supporting to make these transmission chains and precision to a point where we can say we know the index case and is highly linked to zoonotic origin, which was also corroborating with the sequencing results. This is our sequencing data that we've been working on in our lab with different partners that we thank. So the sequence for this virus in Rwanda is what we see, we call October strain, which is very close to another strain or genome that was reported in the region, 2014, and also very close to a genome that was reported among in that zoonotic link that I talked about among bats in the region. So that information coming together, about 5 points of information connecting to what we see here as sequence results, actually put us in a situation to say this virus was from a zoonotic origin, is very close to what we've seen in the region before, and that the virus didn't change that much in the last 10 years because the transformation, the change in the strains looks like very, very small, and that it didn't pass through different hosts to have had these mutations. So it's a very important information for those who are in this field. We'll be talking about for colleagues who have worked on this sequencing, maybe for additional information. So we've had many questions about case management, how the clinical and doctors, nurses, allied scientists, IPC, and everyone came together to make sure we get the lowest case fatality rate in any Marburg outbreak before. Yet it came in a very difficult, unusual city, in a capital, in an ICU, in a hospital. And I would really want to pause here to thank all health workers, especially the teams that worked in treatment centers, to have managed to keep this case fatality rate at a very low level, 24%. And the answer to this is that teamwork, and there are many efforts done on providing antivirals, use of different therapeutics, some on trials, some are already what we had to make sure the patients who were being followed, we call them patients, but mostly they were health experts who are now being treated, they get the best outcome of this. So the supportive treatment, even critical care, the ICU specialists who worked around this have done this possible. And we got great news. Actually, yesterday I was with Dr. Tedros visiting the treatment center, seeing that the 2 patients who have been on intubation for more than 10 days have been extubated. It's the best news you can expect in any treatments in any hospital when someone has been in intubation for a very long time, being extubated and doing well. It was a great celebration that these 2 people are going also to get out of this virus and go back to work. So this is something we want also to highlight, that even if you get this virus, you can get the best treatment and recover and even continue to contribute to the science, because understand this is the first time in the history that a patient intubated on Marburg get extubated successfully. So, and probably the last slide is on the how Rwanda makes sure we don't get virus out of our control. How do we make sure also within at our borders we screen at the airports, at the entry points, at the borders, land borders and water borders. So we continue to do this screening at the Kigali International Airport for these contacts, but also to make sure we don't miss any case. I want also to highlight that beside the list of contacts we had in our contact tracing teams, we've been following everyone with symptoms suggestive to Marburg virus to call us and tell us. And all we tested in the last 4 weeks, no one tested positive for Marburg, which is a great news that we don't have community transmission for Marburg. That's also a key indicator. And we are going to continue to do that because we are not yet at the end. That everyone with high fever, with severe headache, with muscle pain, with joint pain, fatigue, diarrhea, vomiting, calling 114, and we make sure we assess and evacuate and test, and that we don't miss any positive case, even if it's beyond our contacts. So with these past weeks, we've confirmed that all our positive cases came from our list of contacts. So that is up to now, and we are going to continue. It's not the end, but is a great step forward towards stopping this outbreak. So I'd like to also acknowledge other tools we've acquired, including vaccination, which came very quickly. It's rapid access and deployment of this vaccine that is one of the factors that we are seeing rapid containment of the virus. We've been vaccinating the healthcare workers at the front line, the contacts of cases, and this also reassured those who are at service, but those who have been in contact that you're not going to get the virus. At least you have another level of protection. So we have reached more than 1,000 people receiving this vaccination. And we thank all our partners who have contributed to this effort. And they are here in the room, so we want also to appreciate your support. And when time comes, you may also make some comment on this. And so far, the uptake and the follow-up on any adverse events is going well. And we believe that is also a great contribution to what we can do when an outbreak happens, how quick we can deploy tools that are showing good success. So I thank you very much for your attention and look forward to your question and comments. Murakoze.